us today at our CT and MRI lecture series. Today is a great pleasure to have Dr. Gianluca Pontone join us to talk about cardiac CT from plaque imaging to ischemia detection and what we can learn about from cardiac CT. So Dr. Pontone is both a cardiologist and a radiologist, so he exemplifies this relationship between cardiology and radiology. He's a director of the MRI and deputy director of cardiovascular CT unit at Centro Cardiologico Monsino at the University of Milan. And he has over 400 publications and has done he's in almost every important publication currently for cardiac CT. So thank you very much for joining us. A pleasure to have you.
Thank you very much, Leandro, for this kind introduction and for this invitation to join to your amazing session that I have also followed in the previous event. So really congratulations for this initiative. I will talk about cardiac CT and specifically how we can move from plaque imaging to ischemia detection with this technique. Let me just start with the first point. To better understand exactly which is the additional value of cardiac CT in this setting, we have to start from the evidence of the guidelines to better understand the limitation of the previous guidelines and then to move in the direction of the new guidelines because they can explain exactly what is the additional value of cardiac CT in this setting. The use of non-invasive multimodality imaging is a great resource for us, but it is also a very important reason for healthcare budget increase because, as you can see in this slide, the responsibility of cardiac imaging and specifically in the field of cardiology is huge in terms of increase of cost in the management of the healthcare. So we need really to better understand the appropriateness of and the correct use of these imaging techniques because we have to remember that our aims are to improve the yield of diagnostic algorithm, this in order to improve the patient outcome and symptoms, but we need to stay within sustainable cost margins. And of course, it's very important that these techniques are safe. Starting from this evidence, I want just to consider a couple of dates as milestone of my speech. The first date is 2010, because this was the date in which David Cameron was voted as a UK Prime Minister, and is exactly the same year in which the NICE guidelines on chest pain were published and then updated 6 years later in 2016. In Europe, what happened? In 2013, Cameron announced Brexit referendum, and now everybody knows how this referendum finished. And that was exactly the same year of the publication of the European guideline on stable coronary artery disease that was updated 7 years later in 2019. So let me just start from the previous guidelines. I mean, the guidelines published in 2013. There were three main steps in these guidelines in the past that was at the base of our clinical approach for the patient with suspected coronary artery disease. Step one, to define the pretest likelihood of coronary artery disease. Then, based on the pretest likelihood of coronary artery disease, to select the most appropriate test. And based on the evidence of the result of this test, we can do a risk stratification of the patient and then to guide the treatment. Basically, the previous guidelines suggest to use non-invasive imaging tests in all patients with intermediate risk of coronary artery disease, I mean, ranging between 25% up to 85%. So that was exactly what the previous guidelines suggest. But starting from the Conform registry, a huge experience that we performed with several groups from US as well, there was a great observation that if we compare the expected prevalence of coronary artery disease based on clinical risk score as compared to the observed prevalence of coronary artery disease when we scan this patient with CT, there is clear evidence that the clinical score overestimate the presence of coronary artery disease. In some cases, the difference is very impressive. Of course, if we consider all cardiovascular risk factors that we have in our hands, Framingham is just one example. This is a list of the most famous clinical score that you can apply in your clinical practice. What is important to underline is that if we use a score that is responsible for an overestimation of the pretest likelihood of coronary artery disease, there is a potential risk to assign the patient to the wrong test, because if the estimation is wrong, the decision to use that test rather than another one could be based on mistake. This is not the only limitation of the previous guidelines. I mean, the wrong estimation of pretest likelihood of coronary artery disease. There is another social aspect. I mean that we know that when we evaluate the risk of a patient with a clinical score, we estimate the risk to have some events. But there is a very common experience in clinical practice that when you have a theoretical estimation of the risk for events, this usually is not enough robust motivation to push on the patient to modify the lifestyle or to start with the primary prevention therapy and so on. And we have a very common experience in the field of hurricane. Everybody knows the risk related to the presence of hurricane. Everybody knows where this hurricane can occur, which area are at risk for this. But despite that we are able to predict all this information, we continue to build a community, town and city in area where there is the risk to have this kind of phenomenon. And what happened in medicine is probably exactly the same. And indeed, everybody knows that the majority of myocardial infarction occurs usually in patients with non-obstructive coronary artery disease. So the challenge is now how we are able to identify the patient with subclinical atherosclerosis in order to avoid the first event, I mean myocardial infarction, and at the same time to guide a modification of lifestyle and to start with primary prevention therapy. There are several papers. This is an elegant meta-analysis that was published on some years ago, in which there was clear evidence that the most cost-effectiveness approach based on the pretest likelihood of coronary artery disease is usually based on the combination of two tests. For example, SPECT and CT or ECHO and CT and CT and MR and so on. And this regardless the threshold used to define the presence of obstructive coronary artery disease. The message of this meta-analysis is that the double approach means that we need anatomical and functional information to better manage this kind of patient. So for this reason, in 2019, the guidelines has changed, and there were a lot of changes in the clinical practice. The most important changes was related to the reduction of the importance of the pretest likelihood of coronary artery disease estimation. Indeed, according to the new guidelines, actually there is no rigid classification in low risk, intermediate, or high risk, but there is a sort of continuum between these three categories, and the selection of the most appropriate test for the patient is not a binary choice, but is a sort of continuum choice in which there are some situations, green color, in which the test is absolutely appropriate. There are some situations, red color, in which the test is absolutely not indicated. And then there is a sort of gray area, gray zone, in which the use of the test is under debate. If you look at the cardiac CT, the coronary CT in these guidelines, you can see that a potential appropriate use of CT is extremely extensive, starting from the very low risk up to intermediate to high risk. So the most important message of these guidelines is that the use of cardiac CT was absolutely extended as compared to the previous version of the guidelines, and indeed actually is in class 1, level B. And the final conclusion of these guidelines is that basically, if you have a patient with suspected coronary artery disease, you can start with cardiac CT as a first-line test, and you don't need to use CT just as alternative in patients with equivocal functional stress imaging. If we follow the guidelines and we start from the cardiac CT as first line, we need to predict what could happen when we start from an anatomical approach. When you scan a patient, we need to derive three main information. The first two information is to identify the subclinical atherosclerosis and to identify the adverse morphological characteristics and eventually the metabolic activity of the plaque. Then, when you have an obstructive coronary artery disease, you need to detect also ischemia. What about the first 2 points, adverse morphologic characteristics? This is a very elegant slide provided by Paul Morovich-Horvat, in which it is summarized in one slide the potentiality to perform a prognostic stratification of a patient according to the presence of subclinical atherosclerosis, in which plaque characteristics are provided, are defined. There are 4 features that are associated with an higher risk of event, and these features are low CT attenuation, napkin ring sign, spot decalcification, and positive remodeling. And all these events are associated with an increased hazard ratio for major adverse cardiac event, 2.9 for low CT attenuation, 5 for napkin ring sign, we have more than 2 for spot decalcification, and again, we have 2.5 for positive remodeling. But if we detect subclinical atherosclerosis and in this way we identify a subset of patients at higher risk of event, we need to understand how to use this information to manage the patient. In the history of cardiology, there are some very important milestones that has really changed the outcome of the patient. This is just a description of the most important milestone in the history of cardiology, able to decline the cardiac death due to cardiovascular disease. And one of the most important milestones, as you know, is the introduction of the statin therapy. Indeed, the statin therapy is able to improve the outcome of the patient, and everybody knows. And there is the concept that to predict the event, you need to reduce the cholesterol level, and this is true. But probably the indirect effect to improve the outcome by statin therapy is plaque mediated rather than cholesterol level mediated. And this evidence was clearly described in the consortium in which we have enrolled patients with 2 sequential CT, one CT at the baseline and one CT after 2-3 years, in which we have checked what happened at the clinical plaque at a subset of statin. We have found a decrease of a non-calcified lesion. So paradoxical, when you use statin therapy, you can observe an increase of calcium score, for example. But this does not mean that the risk of a patient is worse. We are just shifting the plaque phenotype from unstable plaque toward stable plaque. And this is probably the mechanism that there is behind the improvement of the outcome when you treat the patient with statin. This is important because, as showed in this meta-analysis, the statin therapy, there is a consensus that the statin therapy is mainly associated with the volume regression. And there are a lot of quantitative markers that we can measure by CT, for example, the total plaque volume, the low attenuation plaque volume, and so on, the calcium plaque volume. And these are quantitative parameters that we can measure with the CT, and that could be very useful tool to guide the primary prevention therapy, because we know based on meta-analysis that when we treat the patient, all these parameters are reduced except for calcium plaque volume. Of course, the possibility to detect what happened in terms of atherosclerosis open the scenario of the treatment to guide the treatment with statin, of course, but there are also very interesting emerging data about the pericoronary adipose tissue. This is the technical approach to measure the attenuation of the fat around the coronary arteries. And there are several publications that have showed that, for example, there are some specific threshold. In this case is minus 70 ounce-field unit, who are able to distinguish patients with adverse event as compared to the patient with better outcome. Because the pericoronary adipose tissue is usually an indirect index of the metabolism, plaque activity, as you prefer. And so based on this quantification, we can also imagine if the plaque is an active plaque versus not active plaque. And this is important in the area in which, for example, the anti-inflammatory therapy was recently introduced to manage and to treat the patient with stable or not stable coronary artery disease. Okay, so cardiac CT is able because is useful because we can use behind the estimation of the pretest likelihood of coronary artery disease. Second is the unique technique to detect the subclinical atherosclerosis. But what happens when we find an obstructive coronary artery disease? In this case, there is a potential role of adverse hemodynamic characteristics detection. This is a recent meta-analysis, very updated meta-analysis that we published last year on International Journal of Cardiology, in which we have compared in terms of diagnostic accuracy all imaging modality versus invasive FFR, but as compared to the previous meta-analysis, the novelty of this meta-analysis is that we have included all technique, also the most recent. I'm talking about FFR-CT, for example, and we have also included the stress myocardial Ct perfusion. What we observe in this our meta-analysis that CT, as expected, is the best ruler out. So when CT is negative, is negative. But we have also observed that the CT is the worst ruler in, because when you detect an obstructive coronary artery disease, okay, it's an important information, but it is just a piece of the puzzle. It's not enough to decide if the patient has ischemia, apparently. In this setting, the top techniques are stress MR, for example, PET, and a very good position, the green color, for the stress CT perfusion. So starting from this evidence, the most expected approach is that if you find a patient with a CT, with a positive CT, obstructive coronary artery disease, and you need to detect ischemia, you can move, for example, to stress MR in case. And let me just spend some words about stress MR, just some slides. Everybody knows how stress MR it works. This is, for example, an arrest acquisition perfusion study. This is a stress perfusion study with a clear evidence of perfusion defect in the lateral wall. The point of strength of stress MR is that we are able to detect both steps of ischemic cascade. I mean, perfusion effect and also wall motion abnormalities associated. And we know also that when we compare the diagnostic performance of stress MR versus invasive FFR, the performance is really good. Sensitivity ranging between 82% up to 91%, or in terms of specificity, we have a range between 74% up to 85%, for example. In this meta-analysis, very famous meta-analysis of Nandalur, published more than 10 years ago, the mean sensitivity and specificity for stress-induced wall motion abnormality was 83 and 86% respectively, and perfusion imaging sensitivity 91 and specificity 81. Also, when we compare stress MR with SPECT, for example, very good performance, because as known, CMR has a higher sensitivity. This is the CMARC, 86% up to 66%, and comparable specificity, for example. And this is just a meta-analysis on the prognostic value of stress MR. Stress MR is not only a test with a binary result, positive or negative, but of course, we can, for example, to estimate with a semi-quantitative approach the amount of the ischemic burden. And for example, Vincenti showed that when we found more than 1.5 segment involved by myocardial ischemia with stress MR, this usually is associated with a worse prognosis. And this is our experience published some years ago in European Radiology. We demonstrated that if the CMR is negative, the outcome is good. If we found just perfusion defect, green line, the outcome is worse. The worst scenario is the combined presence of perfusion defect and wall motion abnormality. This is an example of a patient with an acquisition in rest condition, no problem. In the stress condition, you can see in the same sequences the perfusion defect and also wall motion abnormality in the anterior wall. This is the perfusion defect here with a clear evidence of perfusion defect in the anterior wall of left ventricle. Viability in the anterior wall at the left gadolinium enhancement. So this is a clear, in this patient, there is a clear evidence that the patient needs to be treated. So starting from this evidence, the MR-informed study suggests that a strategy based on the combination of stress MR plus invasive coronary angiography is comparable with the full invasive approach, I mean invasive FFR plus invasive coronary angiography. So CMR seems to be very robust. And the question that we had in our mind 2 to 3, 4 years ago is, okay, if stress MR is so robust, we need to understand if when we have a patient, challenging patient with obstructive coronary artery disease, previous revascularization by stent, and so on, if stress MR is better than CT or the opposite. And we analyzed this aspect in the strategy study, in which we enrolled 300 patients in CT arm and then 300 patients in stress MR, and we followed these 2 patients in terms of downstream non-invasive test, rate of invasive coronary angiography, PCI, radiation exposure, cumulative cost, and MACE. The first evidence in this challenging anatomical setting was that CMR was associated with a lower downstream non-invasive test. Same for invasive coronary angiography. CMR strategy was associated with a lower referring to invasive coronary angiography. And as a consequence, we had the lower rate of revascularization in CMR group, and of course, lower radiation exposure. But this is not an important point, because probably with CT we do more diagnosis, and if we do more diagnosis and we treat this patient, probably we can improve the outcome of this patient. But when we compare the MACE between the CMR strategy and the CT strategy, it seems that despite CT refer more patients to the cath lab, at the same time we have a higher rate of event as compared to CMR. So definitely we demonstrate in the strategy 1 study that the cost effectiveness of stress MR strategy in patients with challenging anatomical setting, non-coronary artery disease or revascularization and so on, is better than as compared to the CT strategy. So CMR apparently win against CT. But in 2 years ago, it was published this very interesting paper, the DANI-CAD study. Usually, we have a clear idea in our mind regarding to the performance of stress MR and of all stress imaging tests in the patient with intermediate risk, in which we don't know the coronary artery anatomy. This is the typical setting in which diagnostic performance of these tests was, this imaging modality was tested in the literature. But in DANI-CAD study, Nissen tested the performance of SPECT, for example, and stress MR in a specific subset of a patient in which there was already proven obstructive coronary artery disease in CT. And the evidence was that the sensitivity of both tests was extremely low. This is a very important information, because if, according to the new guidelines, we start to approach this patient with an anatomical test by using CT, it means that in the future, the stress imaging will be mainly applied in the subset of patients with non-obstructive coronary artery disease. And if the sensitivity of the test in this subset is so low, this could be a problem. And probably we need to imagine also some alternatives. The alternatives are potentially FFRCT and stress CTP. Everybody knows FFRCT. We have started to work with FFRCT several years ago, in 2002, so 8 years ago. How it works, this is a sort of 3D model starting from the 3D dataset, CT dataset, and by application of computational fluidodynamic models, there is a sort of simulation of FFRCT quantification. This is a patient with high degree stenosis of LAD. This is the invasive the FFRCT estimation, and the same tool as the stent planner. I mean, you can simulate the stent application, then to recalculate the expected FFR in this patient. Several publications were done in this setting. The first one was the NXT trial, in which the diagnostic accuracy of FFRCT was tested. In an NXT trial, Björn Nogard compared the FFRCT versus invasive FFR, and what he found was that when you add FFRCT on top of CTA, the diagnostic accuracy was improved from 53% up to 81%. So excellent accuracy of FFRCT. We observe also an excellent reproducibility, because when you compare reading 1 versus reading 2, there is a Pearson correlation of 0.98. So it's extremely reproducible analysis. But what about the cost effectiveness? Because you can have a test with the high diagnostic accuracy, but that is not cost effectiveness, for example. And we tested the cost effectiveness of FFRCT in the platform trial. What we demonstrated in the platform trial, we demonstrated that if you compare the usual care versus FFRCT, there is a great advantage of the use of FFRCT as gatekeeper to invasive corneal angiography. Just a couple of numbers. When you use the usual care, you have the majority of patients with no obstructive coronary artery disease at invasive angiography. If you use an FFRCT approach, you can cancel 61% of invasive coronary angiography, and just 12% of patients referred to the cath lab has no obstructive coronary artery disease. Among the patients in which the invasive FFR, the invasive evaluation was cancelled, no events were observed during the follow-up. This is just a very nice picture provided by Leslie Shaw, in which this is the usual care cohort. The patients are referred to the cath lab. Minority of this patient needs to be revascularized. The majority of the patient has no obstructive disease. So cath lab to rule out. If we use an FFRCT approach, the majority of patients are referred to the medical therapy, avoiding invasive evaluation. Just a minority of patients are referred to invasive coronary angiography, and among these, the majority are usually treated for revascularization. The direct effect of this approach is to reduce the overall cost. And the estimation of a reduction of overall cost of an FFRCT approach versus an standard of care approach range between 23% up to 26%. The FFRCT was proved to have also prognostic value. In the advanced trial, in which we enrolled more than 5,000 patients, in which we demonstrate that if you have an obstructive coronary artery disease with a negative FFRCT, you have a very low risk of event at 90 days, but also in a 1-year follow-up. FFRCT is not only diagnosis and prognostic stratification, but more recently was introduced as a fantastic tool also to guide the revascularization therapy. Everybody knows that the most common tool used to decide how to revascularize the patient, PCI versus CABG, for example, is the syntax score. And if we compare the syntax score calculated by CT versus invasive coronary angiography, we found, as expected, that the syntax score by CT usually is overestimated as compared to the traditional syntax score by cath lab. But if we integrated CT plus FFRCT, the syntax score is absolutely comparable with the syntax score of invasive coronary angiography. According to this evidence, in 2018, we published with Patrick Serruis and Carlos Collet the syntax 3 study, in which we enrolled patients with 3 vessel disease. These patients were evaluated by CT, and then we randomized the R team in 2 different scenarios. In one case, the R team evaluated the syntax score based on traditional approach, I mean invasive coronary angiography. And in the other setting, in the second group, the art team evaluated the syntax score according to the CT plus eventually FFR CT. And when we compare the two art team recommendation, there was a very high degree, a very high agreement. 93% of agreement between the two art team. This means that we can decide to suggest PCI or cabbage or both with the same diagnostic accuracy of invasive evaluation. Just some numbers to better understand this concept. FFRCT has changed the decision for PCI or cabbage in 7% of patients. FFRCT changed the indication of the vessel to be revascularized in 12% of a patient. But more important, FFRCT reduced the number of hemodynamically significant vessel coronary artery disease of 13%. According to this evidence, we have just started 2 years ago, and we have at 75–80% of rate of enrollment with Pamela Douglas, the precise protocol, in which we are comparing two strategy. I mean, FFRCT strategy versus usual care. In other words, is the same message of the platform trial, but in this case, in a randomized trial. But FFRCT is not the only novelty that we have in this setting, because there is also the stress CT perfusion. The stress CT perfusion is the last technique introduced on in the portfolio of multimodality imaging, and it is the possibility to detect ischemia with CT. You can do in static and dynamic approach. This was our experience with the wall art coverage CT that was published 2 years ago on JACC imaging, in which we compared we tested the diagnostic accuracy of stress CT perfusion, static stress CT perfusion, as compared to the invasive coronary angiography. And as you can see here, there is a clear evidence that when you add the perfusion red line on top of CTA black line, there is an improvement of diagnostic accuracy from 76 up to 89% by using invasive FFR as a reference technique. This is just an example, a patient with 3-vessel disease and multiple perfusion defect in inferior septum in anterolateral wall. And these data were confirmed by invasive coronary angiography plus invasive FFR. But the limitation of the CTP is that you need to scan the patient twice for rest acquisition and stress acquisition. This means double use of radiation exposure, double use of contrast agent, and this could be a limitation. But we have experienced with the last generation CT scanner that this new technology is able to tolerate the motion artifact related to the heart rate. And so one of the answers that we had in our mind in the last 2 years was, but if I stress the patient with the stressor, adenosine or regadenosin, whatever you want, and when I acquire the stress data set to evaluate the perfusion under stress, if the image quality of coronary arteries is enough to evaluate the coronary artery anatomy, why we cannot use one single stress data set? We compared these two approaches in this experience, and we found, for example, and we compared the rest stress approach, blue bar, versus the stress approach alone, green bar, and we found in this our experience that the diagnostic accuracy was the same, but the overall radiation exposure was for the second approach just 2 millisieverts to provide anatomical and functional information. This is just an example. These are the coronary arteries, panel A and B in the rest dataset, and this is the coronary artery anatomy of the same patient in the stress dataset. And as you can see here, the image quality is quite comparable. Multiple perfusion defect confirmed by invasive FFR. But the perfusion CT is not only static approach. Perfusion CT, it is also a dynamic approach. So you can calculate the myocardial blood flow, mimicking a bit what PET is able to perform since the last 10–15 years. And this is our experience with dynamic CT approach, in which, again, we demonstrated that when we add the dynamic CT perfusion, red color, on top of the CTA anatomy alone, black color, there is an increase of diagnostic accuracy from 78% up to 87%. So very huge result as well. But what is important is our experience is that we have developed a low dose dynamic CTP protocol. Indeed, the mean effective dose was just 5 millisievert in our experience. Just let me show you one example. This is a patient with multiple lesion on LAD, and this is the dynamic Ct perfusion. As you can see here, there is a black area here in the septum, here and here. Then we dedicated the color map. We can display the area where the myocardial blood flow is very low. If you put a region of interest here, you can calculate, for example, a very low myocardial blood flow, 45 milliliter in this case. Effective dose, 5 milliliter, so very comparable. So the next question is, okay, we have a static CTP, we have dynamic CTP, but we have also FFRCT. What we have to use? Because there is the risk that when we have too much tools, then we don't know what tool has to be used. So for this reason, in the perfection study, we have decided to compare these two new techniques, FFRCT versus CTP, in this case, static CTP. And what we demonstrated in the perfection trial is that when you do an head-to-head comparison between FFRCT and stress CTP, the diagnostic accuracy is quite comparable. This is an example, 2 lesions on 2 vessels, normal perfusion, and indeed, this patient is also normal FFRCT. This is another patient with multiple lesions on LAD, on left circumflex artery, and so on, with multiple perfusion defects. So 2 vessel disease and very huge amount of myocardial ischemia. When you do the FFRCT in this patient, you have just 1 single vessel disease. So it seems apparently to have a disagreement between FFRCT and perfusion and CT anatomical tool. But this is not true, because if you check the distribution of the vessel here of the LAD, you can understand that this is responsible for a very large territory, myocardial territory. This means that from functional point of view is 1 single vessel disease, but with 2 vessel disease from functional point of view. So considering that we have 2 techniques that are comparable, we need to decide if there is an integration in terms of sequential strategy. And in the Ripcord CTP study, just published 1 month ago, we have compared different strategies among them. CT alone, CT followed by FFRCT, CT followed by CTP, or a sequential strategy, CT plus FFRCT plus CTP, where the CTP is just applied in patients in which we have an FFRCT value in an equivocal range, I mean between 0.7 and 0.8. As you can see here, the sequential strategy here is the strategy associated with the best compromise in terms of rate of reclassification, in terms of rate of agreement with the final decision to revascularize or not, in terms of rate of agreement with decision to treat that specific vessel with absolutely comparable effective radiation exposure as compared to, for example, the strategy in which we do perfusion in all patients. So for this reason, we've just started a multi-center trial that is at the beginning of enrollment, the CTP Pro study, in which we are comparing now 2 strategies, CT strategy plus perfusion, CT perfusion versus standard of care, 2,000 patients to be enrolled and 2 years follow-up, and the study is still ongoing. But just let me move to the last 2-3 minutes of my presentation. Okay, the guidelines suggest to do an extensive use of cardiac CT, okay. Cardiac CT is very useful to rule out, or in case to rule in subclinical atherosclerosis to guide the primary prevention therapy. In case you find an obstructive coronary artery disease, you need eventually to detect ischemia. Despite this point is under debate after the publication of ischemia trial, but anyway, you need to detect ischemia. And in case you can use traditional tests, but now you can use FFRCT and CTP, and these 2 tools are comparable in terms of diagnostic accuracy, and therefore a sequential strategy is suggested. But the last question of my talk is if we really need to detect ischemia, or plaque imaging is enough to describe everything. We have an initial answer to this question from our experience of credence trial that we performed with Jin Min and Leslie Shaw and with most of other friends and colleagues from US, in which we have enrolled a patient scheduled for invasive coronary angiography, in which there was available one CT and one stress perfusion imaging technique, SPECT and mainly, and a stress MR. And all these patients were referred to invasive coronary angiography and invasive FFR. And what we found, for example, that if we use an anatomical model in which, based on stenosis severity, we're able to predict the ischemia with an accuracy of 82%. But if we imagine a more complex concept of an anatomical model in which stenosis severity is just one piece of the puzzle, but we add on top other parameters such as non-calcified plaque volume, number of lesions, lumen volume, presence of iris plaque or not, and so on, the power of the predictive model is increased from 82% up to 80%. And in case we want to add on top of this complex anatomical model and a functional tool, for example, the FFRCT in this case, there is no further improvement. In other words, it seems that when you discuss of an anatomical model in which you include all parameters and not just stenosis severity, probably you have more than you need to predict if the patient has ischemia or not. So for this reason, a new era of simulated predictive model has just started, thanks to the artificial intelligence, for example. And this is our experience of the perdition study that we have just submitted now, in which we have used an artificial intelligence-based tool to predict the myocardial blood flow, the ischemia, and we have compared the performance versus the true stress CTP. In other words, virtual stress CTP versus true stress CTP. And for example, if you see this column here, you can see that the negative predictive value of a combination of CT anatomy plus virtual stress CTP is very high. And the accuracy very comparable as compared to the true stress CTP. So the message of this preliminary experience is that probably you can start with CT, then you can launch an artificial intelligence-based solution to predict if you really need to go ahead with the perfusion or not. And this tool works really in less than 1 minute. So you can take this decision in real time. Or if you don't believe in artificial intelligence, of course, you can use Fluidodynamic. This is a software that we have developed with our engineer colleagues from Polytechnic of Milan, in which we have used the sort of simulated myocardial blood flow estimation. And this is, for example, the comparison between a myocardial blood flow map based on the true stress CTP versus the myocardial blood flow map reached by a simulator. And as you can see, for example, in patient 3, there is a good agreement. Also a good agreement in the patient 5, and also in patient 9 and patient 10. So just let me move to the final message. We have in the history of cardiology and of ischemic heart disease 3 main areas. The courage area, in which we have treated mainly ischemia. Then there was the fame area, in which we treat still ischemia, but at the vessel level and not at the myocardial level. But after the Scott heart, now we are in the Scott heart area, in which first we treat atherosclerosis, and then eventually, question tag, the ischemia. And probably in this setting, the cardiac CT is a very important tool to give us the information that we need in this new era. I want just to close my presentation, just to remember that as a European Association of Cardiology, we've started with a training and a certification process for cardiac computed tomography. So for the people who are interested to be on board on that, please let me know. And also our residential training course in multimodality imaging, echocardiography, cardiovascular CT, and cardiac magnetic resonance. And my last slide is for my department, for the people who works in this amazing group, because I want really to thank them for all their contribution, because that is the key of our department, and I am here just to represent all of them. And thank you very much for your attention.
Thank you very much. That was a great talk and beautiful pictures. So please, for everyone, put in your Q&A the questions, and we'll go over the questions. I'll start with one, actually two. If you could comment on the late iodine, and when would you use late iodine? And the second question, if you have tried the AI algorithms for stents, if you think there's a future there on stents and using AI for restenosis.
Yeah. Regarding to the first question, yes, we are growing in terms of experience of about the use of cardiac CT for late enhancement with the iodine. We are just a paper now under evaluation on that. The message is that is quite robust, so you can do mainly in ischemic heart disease, a bit more complicated in non-ischemic heart disease, because you need a sort of amount of scar to be detected. And as you know, sometimes in myocarditis, the scar is very small. On the contrary, in the ischemic heart disease, the amount is higher, so it works better in ischemic heart disease. The main problem of the late enhancement in CT is that to have a good image quality, you need a huge amount of contrast volume. I mean that you need, for example, for a standard patient, absolutely more than 100 milliliter of contrast agent. And thanks to the last generation scanner, everybody knows that now for just coronary artery evaluation, 40, 50 milliliter are more than enough. So the use of detection of late enhancement with in CT is in the opposite direction, because it requires more contrast agent, but in the clinical practice we are going exactly in the other direction. So this is my only concern. Probably more chance we can have if we apply AI solution applied to the arterial phase dataset, standard arterial phase, to extract the scar. That is an interesting application. There are some data as well on that. We are working on that as well. And probably I believe that there is more chance in the future to use this approach rather than a traditional late enhancement acquisition. Regarding to the second question, that is a good point, is one of the answer and curiosity in my mind, but in that specific topic, we have not still started to work. And so I have no direct experience and no data to share with you.
Okay, because we can go there. Some questions come in. Someone asked he wants to join fellowship and what to do for that.
Yeah, please send me an email, and then I can evaluate your need, and I can evaluate internally, and open door. So I don't know if my email is available on the website, or otherwise, Leandro, you can send my email to the people who joined to this conversation today, and feel free to discuss.
Okay, perfect. From Rajinder Taplu says, what about post-stent CT, CAG? What about CT or cabbage? I think they're trying to say. Is it helpful? Or...
Okay, after you mean in patient with the previous revascularization?
Yes.
Okay, two different settings, cabbage and stent. For cabbage, of course, the technique is extremely robust and extremely useful, because the graft are a big vessel, so there is no issue of spatial resolution, and there are less movement because they are stable vessel. So that is an ideal condition for CT. So actually you can use. The guidelines suggest to check the situation of cabbage after 5 years, 5 years after the revascularization, if they are asymptomatic, of course. So you can use the CT in this dataset. Also, because with the last generation CT scanner, there is an excellent visualization of the distal anastomosis and of the distal vessel after the anastomosis as well. More complex discussion about the stent, because there are some restriction actually regarding to an extensive use of CT in a stent patient. First of all, experience is required, because that is a challenging anatomical setting. So if you are a beginner of CT, I don't suggest to use CT in stent. If you have experience, you can do. Second, in terms of clinical indication, actually you can use, but in specific subset. I mean, left main artery stent, proximal segment of the main coronary artery vessel, and in any case, you can evaluate stent with diameter over than 3 millimeter. Because when you have below 3 millimeter or below 2.75 is extremely challenging. In my opinion, I am not an interventional cardiologist, but in general, I have not clear in my mind from physiological point of view, which is the contribution to the circulation of a 2.5 millimeter stent. But anyway, the patient has this kind of stent, and in case you have to evaluate this patient.
Do you use any quantitative approach to evaluate stents? Any changes in household unit?
We try to do, but to be honest, the reproducibility is not so high. So we have a really binary qualitative approach. I mean, ISR below 50 or over 50 is more practical and more reproducible.
Okay. So I'm not sure. Asim Latif is asking, and I'm probably going to mispronounce that, but it says, Ciao Gianluca, sono contento di rivederti.
Thanks very much. I hope to go to be in New York City personally in the first occasion after the pandemic. So just to meet Latif, Luigi, and a lot of friends that I have in your hospital.
We'll be happy to have you here. He says also, how far or close are we from being able to diagnose vulnerable plaque using CT? And second question, he says, how often are you able to evaluate coronaries sufficiently on a pre-TAVR CT?
Okay. Regarding to the iris plaque, that is probably the main goal of CT, because there is a very robust and huge amount of evidence regarding to the prognostic value of iris plaque. And also because, as I showed in your presentation, there are also some preliminary and not only preliminary evidence that probably that is a wonderful tool to guide the primary prevention therapy. The quantitative plaque analysis is time consuming. That is the truth. So if you imagine a standard workflow in which you have to scan the patient, then to do the quantitative plaque analysis for each segment, this is difficult to sustain in the real world. So the goal is, okay, iris plaque identification is important. We need to improve the automatic software in terms of reproducibility, in terms of time consuming, because when we have this robust tool, of course, we can put on board in the real clinical world. That is the direction, and we are not so far from that kind of approach. Sorry, the second question that I forgot.
The second question, I think, is a very challenging case. Is what about the pre-TAVR CTs? What do we do with it? How often can we evaluate for CAD in these patients?
Okay, usually our policy that considering that you scan the patient with the CT for annulus, you have the data set of coronary artery anatomy, and therefore you need and you have to try to evaluate in any case, because it's an evaluation with zero cost. So you have to do. Of course, we know that that is a challenging setting, and there is a good risk to overestimate, but there is no risk to underestimate. So starting from this, check, because there is a not negligible percentage of patients in which, despite the age, despite the history of aortic stenosis, there is no CAD. So in those patients, the negative predictive values are still robust, and you can decide to avoid invasive evaluation, especially considering that this patient often have some problem in terms of renal insufficiency. Of course, in the majority of patients, you will find disease. You refer the patient to the cath lab, but the patient should be referred anyway. And the major risk is that you have just overestimated, but you have not generated a new test, because the patient should be addressed to the new test anyway. So my message is, please check to evaluate the coronary artery disease in all patients in which you scan for TAVI.
And those patients are particularly challenging because we cannot do the right for FFR CT or perfusion. They're extremely challenging. Yes. What to do later.
Yes, but there are simulated perfusion with AI. So there are some escape strategy on the ground.
Perfect. There are a few more questions. what about CT in calcified vessels? Calcium score at both ends, both for rule in and rule out of CAD.
Yeah. Okay, there is a bit different approach between, for example, US community and the European community regarding to the calcium score. Indeed, I mean that the calcium score probably is absolutely used in US, and there is a lower use in CT. We need to differentiate what we want from the calcium score. If we want a calcium score for to perform prognostic stratification of the patient, no doubt, is a robust tool. Okay, and so I fully agree about the use in this category, also because now is in guideline, for example, to decide if the patient needs statin or not. On the contrary, if we want to use the calcium score as gatekeeper to invasive coronary angiography to decide if to scan the patient or not, I have some concern on that for a simple reason. In the era of 64 slices scanner, or even before the 16 slices scanner, in which the radiation exposure of the test was very high, 15 millisievert, for example, to use the calcium score with 1 or 2 millisievert was a wonderful approach, because in case of very high calcium score, you can decide to not go ahead because probably the CT angiography is not useful, and you avoid for the patient 15 millisievert. And this makes sense. But in the era of the new technology, which you have, for example, 1 millisievert for calcium score and 1 millisievert for CT angiography, I am not sure that calcium score is a good gatekeeper for another more accurate test that produces the same radiation exposure. So for this second tool, I don't believe that calcium score is a good gatekeeper for CT angiography at the moment.
What do you think? Yeah, I think that's a very good point. With newer scanners, I think probably maybe one use would be in low to intermediate in places where they don't have a newer scanner or they don't have availability, right? Of a
okay.
Luigi,
Gianluca, let me say hi in Italian.
Hi, ciao Luigi.
Ciao, grazie per la bellissima. Thank you very much for this brilliant lecture.
My pleasure, Luigi, and thanks so much for the kind invitation.
No problem.
And, next year, physically in New York. Next year,
it was not, you know, it's Leandro put this together on their side, and they said, "Do you know this guy?" I said, "Well, I think I know very well." Also, you know, we also can expand a little bit on, you know, the relevance of what you do with CT scan for the arrhythmia point of view. There's a lot we can discuss about.
Yes, absolutely. This topic was focused on coronary artery disease, but there is a huge amount of data also in the second topic.
Maybe the next invitation in person will be on the role of CT scan for ablation.
Yes. But in this case, I will join CT and MR, because in that setting there is a huge combination of these two techniques. Less in coronary artery disease.
The question I have for everybody is that we hear a lot about the role of MRI for, you know, the scar in the left atrium, which is questionable and not reproduced by many. I mean, do you think that in future there will be a role for CT scan to identify fibrosis or scar in the left atrium in a more reproducible way?
Yes, this is a good question. Let me just start from the MR, because I have worked in the CAF2 trial that has finished the enrollment, and now we are doing Marushi is doing the analysis, of course. And we confirmed two things, that in MR, the left atrial scar you can detect. The problem is that in my site, I don't know in the other site, that the rate of rejection of a CMR dataset was not negligible, up to 20% in our experience, because the scan is really challenging. You need to be very skilled to have a good image quality. That is the point. In CT, you can do. I am not so convinced that you are able to see with the robustness properly the scar of the left atrial wall, but you can see very well the epicardial tissue around the left atrium, that some preliminary data are showing are correlated in terms of physiology about what is happening at the wall level. So probably, I mean that we need to imagine the role of CT in a more enlarged concept of left atrial scar and not properly scar in the traditional meaning. That is my concept.
I really like the idea. Maybe we can do something together with Leandro and you and collaborate on a project.
Yes, wonderful. Open door for me, and absolutely.
And we wait for you here in New York. Thank you very much.
Thank you. I hope to see you in Italy as well.
You will see me soon. You will see me soon.
Okay. Thank you very much, guys, for the invitation. It was a great pleasure.